Our next speaker is another, actually, is a true Minnesota product, Dr. Melena Bellin. She is from Minnesota. The only time in her education that she spent outside, if I see that correct here, was when you got your BA at Cornell. Is that correct? Dr. Bellin is associate professor, and she is the director of the Islet auto-transplant program. She is a member of the Department of Pediatrics. She is currently the PI on several NIH grants, active grants. She has over 100 publications, and she has extensively published about islet auto-transplants in children. And as you know, there are very few institutions that have done pediatric islet transplants, but Minnesota is really the mammoth amongst these institutions, having done almost 150 or so. And Dr. Bellin will tell us, where things are with regard to pediatric transplantation.
Thank you. Well, I was charged with this title of TPIAT in children and adults, so I'm going to give you a lot of pediatric data, but I'll actually present that in the context of the entire program. So I'll talk a little bit first about the clinical rationale for TPIAT, but I think you've heard a great deal about that from the speakers this morning, why we do this procedure. And I'm really going to focus then on the outcomes after this procedure using population level data. So I'm going to talk a lot about health-related quality of life, pain outcomes, and narcotic use, because that's really the main reason why we do this procedure. And then I'll go into a little bit more globally the diabetes risk after TPIAT. And I'll embed in here comparing children versus adults. Very similar in many ways, but there's some unique considerations and unique outcomes in children that I think are very interesting to discuss. So you've seen this figure before. You know that chronic pancreatitis is a very painful disease, and I put this up here first and foremost to just reiterate the point that the reason that we're doing TPIAT in these adults and children is not based on diabetes risk. It is the TPIAT is done to treat painful chronic pancreatitis. And what does our population look like? Why do they have pancreatitis in the first place? Well, certainly within the children, we see a lot of hereditary disease. This is mainly disease affecting the genes of the trypsin pathway. So PRSS1 is an autosomal dominant mutation in trypsinogen that leads to autoactivation of trypsinogen to trypsin within the pancreas. And SPINK1 is a trypsin inhibitor, so sort of the other side of that pathway. We also see patients who have 1 or 2 CFTR mutations, not classic lung disease cystic fibrosis, but an exocrine sufficient form of cystic fibrosis at times where they get recurrent acute pancreatitis. It's about 80% of our kids who fit into that population, about actually 15 to 20% of our adults. We also see a lot of idiopathic disease, particularly in adults. We see patients who have pancreas divisum. Now, that oftentimes is complex with genetic mutations. We, once in a while, might see a toxic etiology or an autoimmune etiology. What I didn't put up on this list, which we do see, is we do see a few patients who have alcoholic pancreatitis. I think you heard this morning that actually the majority, a little more than half of patients with chronic pancreatitis do not have alcoholic disease. Those who do have alcoholic disease are oftentimes not great candidates for TPIAT, particularly if they have ongoing chemical dependency issues. So in very selected cases, we have alcoholic pancreatitis, but really the vast majority are idiopathic genetic disease patients. So when disease is refractory to medical and endoscopic interventions, that's when we maybe step up to a TPIAT procedure. Again, I think of this as the primary goal is a pancreatectomy. Our first goal is to relieve pain, improve quality of life, because this is a disease where people who come to surgery are really suffering. And then I think of the islet auto-transplant as a secondary goal of the procedure. So we could do that total pancreatectomy alone, remove the pancreas without the islets and treat the pain component, but the diabetes can be difficult to manage and can thereby impair quality of life. So our goal with the islet auto-transplant is to, as much as we possibly can with the islets that are there, prevent or minimize that post-surgical diabetes. It's a very simplistic diagram of the procedure, so you heard much more about the surgical procedure this morning, but just as a reminder, we are infusing most of the time those islets into the portal vein in the liver. So you heard from Dr. Robertson just before me about how we select patients for surgery. So just a little bit about how our program is based, and I think how many programs are based. We have a multidisciplinary team. So this isn't a surgical program, it's a combined surgical medical program. We get referrals at the University of Minnesota that come from throughout the country. We have a team that consists of multiple surgeons, endocrinologists, GI physicians who specialize in pancreas, nurse coordinators and nurse practitioners, pain doctors, psychologists. Generally, any given week, there's about 10 to 15 of us who meet from 5 to 6:15 p.m. on Wednesdays, and we review every single case. So before the patient gets to us for a TPIAT eval, we sort of do a pre-review. What do they need other than kind of our standard eval process while they're here? And then we have a very comprehensive review after an evaluation process. And when we have that comprehensive review and we're trying to think about should we recommend surgery for this patient or not, this is the list that we're going through. And so first and foremost, we want to make sure that that patient has abdominal pain because they have chronic or recurrent acute pancreatitis. Much of the time this is straightforward. Particularly in children, it's usually straightforward. Once in a while, it's not. And so if we have an adult who has chronic pancreatitis without a real clear history of acute pancreatitis, and they don't have calcifications on their imaging, we are relying on more than one diagnostic test, an MRI, an EUS, pancreatic function test, endoscopic pancreatic function test, to really tell us that that truly is chronic pancreatitis causing their pain, because we really want to avoid doing this major surgery if that is not the source of the pain. We want to do this with people who are actually significantly impaired. So usually the people who get to us to consider for surgery do not have mild chronic pancreatitis. They usually are pretty disabled by the time someone is coming in for this major surgical evaluation. But once in a while not. Sometimes someone comes to us early in the course of recurrent acute or chronic pancreatitis and they're functioning pretty well. And a lot of times this is individualized. So for example, a few weeks ago, I met so I see the adult patients in consult too. I met individual, an adult male who was a firefighter. And so he was working, he had chronic pancreatitis, very clearly had chronic pancreatitis, but he was working full time, he wasn't on opioids, he was managing his pain, and he wanted to come and learn more about surgery, but we ultimately decided this was probably not yet something to go to because the risk of him having to be out of work and have a worsened quality of life because of the surgery we thought was high. So it's not everyone that comes through with chronic pancreatitis who is eligible or a great candidate for this surgery. The next thing on the list is lack of medical and psychosocial contraindications, and I want to highlight this because we see a lot of patients who have significant psychosocial issues around their chronic pancreatitis. So it's really common for these patients to get anxiety, PTSD, depression, and one of the things that we've really tried to ramp up in our program over the past decade is supporting those patients and treating those issues as much as possible before they go through this major surgery, major recovery process. So we have a process that our pain doctors a while back termed prehab. And so we actually have a focus on prehabilitating people to be ready to go through surgery. And a lot of the times that includes physical therapy, it includes sending them, making sure they're established with a psychologist that they can see on a regular basis at home. We see many patients where we defer surgery for 6 months. So we had a little girl who had surgery in December who's doing great. She had hereditary pancreatitis. She came to us in June of last year, and she came to us in a wheelchair, not walking, and not going to school, taking narcotics every day because she was in so much pain. Her mom said she couldn't possibly do those things. And so our pain team worked with her, and a caveat to getting her to surgery was that she had to be going to school. She had to be not using a wheelchair. And by the time she came back for surgery in December, they stopped and did some sightseeing on their way up, and she walked for 8 hours a day. So she still had chronic pain, but she was functional. This is the state we want to get our patients into before they go to surgery. And so then the other things are, ideally, we have a non-diabetic patient, and everyone, even if they're non-diabetic beforehand, has a risk of diabetes, so they have to be willing to manage diabetes. So with that, I'll talk about a couple clinical examples, and then I'll go into the outcomes. And I'm going to give you one clinical example of a child and then one of an adult. So this here is a 4-year-old, not 4 years old anymore, but 4-year-old gal at the time who had recurrent acute pancreatitis that probably started around age 18 months, but many times in these children, they unfortunately don't get diagnosed with the right condition right away. So oftentimes providers, if they haven't seen pancreatitis in a child, aren't thinking pancreatitis. So by the time she was 2, she was properly diagnosed with acute pancreatitis. She was a little bit unusual. She was actually idiopathic, which is usually we see hereditary disease at this age, and she had kind of a chronically enlarged pancreas. There was actually some thought maybe she was autoimmune pancreatitis, so people had tried treating her with high-dose prednisone, with azathioprine, trying to resolve the pancreatitis. She had been to 3 or 4 different specialists around the country before she came to us. She was in the hospital 12 times. She couldn't go more than 2 weeks without having a bout of acute pancreatitis. She was constantly in acute pancreatitis and pain. So that was the context for bringing her to a TPIAT procedure back in 2012 when she was 4. She's not had any hospitalizations since she got out from her surgery admission. She has no pain. She's not been any narcotics since 2012. What I think is actually kind of remarkable about her is they came in one time, maybe it was 3 years or so after surgery, and I always ask if they're having any pain, any pain like pancreatitis, and her mom said, you know, actually she doesn't have any pain, but she doesn't even really remember having pancreatitis or surgery. She asked us where this scar on her abdomen came from. And so just a remarkable tribute, I think, to the resilience of children. They can really just fully recover these things. She has had periods off insulin, but she's mostly been on a low dose of basal insulin. Her A1Cs usually sit in about the 6% range. She actually just had one at 7 years, and I think it was up to 7%, so we're increasing her dose a little bit. But she is C-peptide positive, clearly has great function of her islets, and the diabetes management has just not been an issue at all, and she's been happy and healthy. So in terms of our adult spectrum, we oftentimes see kind of middle-aged, young to middle-aged adults. We see a few more women than men in our population. So this is a 32-year-old woman who came to us with chronic pancreatitis that was idiopathic, so very typical pancreatitis of 7 years. She was very remarkable in a number of ERCP procedures. So she was she was seen by a physician in a program that was very endoscopic heavy. So by the time she saw us, she had had 70 ERCPs. About half of those were to place stents and half of them were to remove stents. And she was on oral morphine, and she had left her job, and she was living with her parents. So that was the context for bringing her to TPIAT. She's someone who we ideally would want to see earlier in this process, not dealing with this for 7 years and 70 ERCPs. She had her surgery in 2011, and she had one admission subsequently in 2016 for lysis of adhesions because she was having some pain and possibly small bowel obstruction issues. And that's fairly common in our adult population to have a little bit of kind of chronic issues here and there. But at 8 years post-op, she's not using any narcotics. She is mostly pain-free, at least she has manageable pain when it occurs. She was insulin independent for 7 years, and then when her A1C went up to 6.8%, we started her on a little bit of basal insulin. She went back to working full-time. She moved out from her parents' house. She got married. She bought a house. So she did all these functional things that she could not do when she was disabled with chronic pancreatitis. So the children versus adults more or less have the same surgical procedure, the same type of evaluation process with the exception of things like child of life and more kind of pediatric focus in the children, but there are some unique considerations. And so these groups of patients, I would argue, differ somewhat in the etiology of their disease. We do see genetic disease in adults, but it is by far the most common thing we see in our children. In our children, we're thinking about things like school attendance. We're thinking about growth and pubertal development, so there's some unique considerations there. You heard earlier about some of the technical challenges with small children when it comes to isolation. There are also technical challenges to doing this surgery on a smaller patient, so that's always a consideration, particularly when we're talking about 3- and 4-year-olds. We usually, if possible, are actually trying to delay that surgery for just a little bit of time to get them a little bit bigger. In any population, adult or pediatric, we need those patients to have a social support system, but mostly in children, we really deal with the parent dynamics and the family dynamics there. And adults are just in general more complicated. Some of our teenagers are complicated as well, but I'd say in general the adults just have more medical comorbidities, more psychological comorbidities, so they're a little bit more of a mixed group. So we have had an active TPIAT program since 1977 when Dr. Sutherland did the first case. It's actually the first case of TPIAT was actually performed to establish that the islet transplant procedure could work for allo-transplants. So it was historically done actually to provide proof of concept for allo-transplant, and then it just evolved over time into a procedure in and of itself to treat these patients with chronic pancreatitis. But I think what you can see here, and this really reflects the growth across the country here, is that the volume was very, very small. and this is somewhere around 2005, 2006, that the volume of patients in the US and at our center who are coming for TPIAT has really dramatically increased. And I think that's really important because that has set up an opportunity for us to actually learn more about this population. And so we have a research program at the University of Minnesota that has evolved over time. In 2005 and before that, there was some very interesting research by Dr. Robertson, Dr. Sutherland, in terms of the metabolic function of the islet, some retrospective case series, some really interesting case reports, including the first pediatric TPIAT. But we really, when we got to having this big volume of patients, that set the stage for some other opportunities in research. And David Sutherland was able to establish in the late 2006 our first observational study in TPIAT. So now in the past 12 years or so, everyone who comes through for surgery is asked to enroll in a prospective follow-up study so that we can collect outcomes data from them. And I won't talk about them much, but have also added some additional clinical trials along the way. So most of the outcomes data I'll show you today evolves from this research program. So what about the pain outcomes and quality of life after TPIAT? Because this obviously is the most important thing for the patient who is coming through to see us. Well, we also look at health-related quality of life scores using an SF-36. So you heard a little bit about that this morning, but it's a standardized health-related quality of life instrument. And if you look at the whole population, the average in the whole population, we see that standard deviation scores improve by about 1 standard deviation score on average on this SF-36. And there are a number of different subcategories that are measured by this SF-36, but the greatest improvements, probably quite logically, are seen around bodily pain scores and physical function scores. So that clearly is what TPIAT is really treating. But we also see improvements in vitality, emotional health, and other areas. We also ask people as part of our observational studies just to provide a perceived health status. So we basically ask them, do you perceive your pain as better now than it was before surgery? And so using that questionnaire, about 85% of patients at pretty much any time point will self-report that their pain is much improved or resolved. The challenge that we have, and I'll kind of come back to this a little bit in this presentation, is that in the entire population, about 15% of patients will say that they have a similar pain burden as before surgery. So one of our big goals has really been to reduce this proportion of patients who have the same pain burden. So what about looking at that quality of life in children versus adults? Are children different there? And yes, they are a little bit different. So this is data that actually is a little bit more than a year old now, pulled from our database of nearly 1,500 responses in nearly 500 patients who have had TPIAT, including just over 100 children. And so the two broad indices that you can pull out of the SF-36 are the mental component summary score and the physical component summary score. And these are actually normalized to a population mean. So if you look at these graphs at the number 50 up here, that's actually what a normal population would be expected to score at. And one of the things you can see, whether we're talking about children who are in the pinkish colored circles there, or the adults who are in the gray squares, is that both of those populations are quite impaired at baseline, as you would expect. So each 10 points here is about 1 standard deviation. So they're sitting about 1.5 to 2 standard deviations below average for their health-related quality of life scores because chronic pancreatitis is such a disabling disease. And then what's quite remarkable is that both groups, adults and children, have a pretty robust improvement in health-related quality of life scores after surgery. What you can notice there is that the children basically normalize on average, and so they have a really robust improvement in health-related quality of life after surgery, and it is sustained, and it is more than the adults statistically. But I don't mean that to draw away from the benefit in adults, because even the adults are improving by 1 standard deviation score on average. I think this just reflects that the adults are a much more mixed group. They carry with them a lot more baggage. And they have more other chronic medical comorbidities that may be contributing to health-related quality of life. But both groups do well, but children do dramatically well. So we do look also at patients who have recurrent acute pancreatitis, but don't have evident chronic pancreatitis on their imaging as candidates for this surgery. There's also very limited medical treatment available for patients who have recurrent acute pancreatitis. And so we see, that's our minority, I would say, but we do see a few of those each year where it's just recurrent acute pancreatitis. What happens is actually you resect this pancreas at surgery, you send it for histopathology, and most of them have chronic pancreatitis on the histopathology. They just didn't have bad enough chronic pancreatitis yet to see it on their MRCP. And what we see in that population is very similar improvements. These are mainly adult patients. They also have an improvement in their health-related quality of life scores on the SF-36. They also very successfully wean off opioid therapy, at least as much as our chronic pancreatitis patients do after surgery. And I'll get back to this opioid use with our entire population, but that's always been a challenge for us to get someone who's chronically on narcotics all the way off narcotics can be a really difficult challenge in this population. So I think that's coming up next. So if we look at this population before they have TPIAT, and we look at children and adults, the vast majority, especially the vast majority of adults, are chronic daily opioid users. Now that is fortunately less frequent in our children, especially now. Pediatricians try to spare opioid therapy whenever possible in children. 100% of these patients use opioids intermittently. So when they get an acute flare of their disease, they're on opioids, but many of them are on everyday, daily opioid therapy. Now, if you look at opioid use, and this is actually really any opioid use after TPIAT, it's dramatically decreased at 1 year. And particularly for children, by 1 year after surgery, about 25% of the children are still using some opioids. That's usually teenagers who have a chronic opioid use history. But about 50% of adults are. And so getting adults completely off opioids has been one of our big challenges. When we look at our pediatric population, we see that withdrawal from opioids does seem to be sustained. So this is a little bit of an older publication, but I think is very consistent with what we still see. And that is that there still are these 10 to 15% of patients who may use some opioids in the pediatric population, but that's fairly sustained, even over a 10-year interval. We see that 90% of these children, if you would just ask them about pain scores, they have improvement in pain scores. And as I showed you previously, they have improvement in health-related quality of life. We like to look at child-specific functional parameters in our children. So we look at in our children on some of the questionnaires that are administered to the parents as part of the observational study. What about school attendance? What about normal childhood function? So this is what these graphs are showing you here. This one is school attendance, and this is limitation just in all childhood activities. And you can see at baseline, the majority of children, they may be attending school, but they're missing a lot of days, so it's interfering with their school attendance before surgery. Most children are limited more than half of the days in a month because of their pancreatitis, and that dramatically improves after surgery. These patients are much more able to attend school regularly, more able to engage in things like sports and clubs and time with friends and family trips and all of this. But when do we fail to improve pain in chronic pancreatitis or recurrent acute pancreatitis? So we looked at this. We looked at this in the entire population because even though we have almost 150 pediatric patients, it's still a relatively small population compared to our total volume of 750. And so this is work that came from Dr. Chinnakotla, who's our pediatric surgeon. And the risk factors in our population to date for failure to either get off narcotics or improve pancreatitis type pain. The biggest one, I think this is consistent with other surgeries in the chronic pancreatitis world, patients who used opioids for a long time before their procedure, 5 years or longer, were more likely to have both chronic pain issues and stay on opioids after the procedure. I think that represents some of the central sensitization and the opioid-induced hyperalgesia problems that happen in this population with long-term narcotic use. And to Dr. Robertson's earlier point about early intervention, I think this, along with the diabetes risk, is another rationale for considering earlier intervention in someone who is likely to go on to need TPIAT surgery. The other ones, are a little bit mixed. More stenting, pancreas divisum, prior Whipple. I think these might have been markers of things in our historic population, and particularly, I think some patients who have divisum may get misdiagnosed as pancreatitis when they have chronic abdominal pain, and that's all that's found, and get exposed to repeated stenting procedures. So I do think that historically we've seen a proportion of the population who maybe had iatrogenic pancreatitis from ERCP interventions, and perhaps their abdominal pain was due to a different etiology. So we have recently looked with Dr. Chinakotla heading this project at 10-year outcomes after TPIAT. So the question was, is this sustained, this benefit that we see in TPIAT? So these were patients who, 215 patients who had TPIAT up until 2008. So they're still kind of a historical population. I have to put this in the caveat that really we have a very standardized medical management and follow-up protocol now after TPIAT, and that was really implemented around late 2006 to about 2019. We implemented all these protocols. So these are patients who were actually not even managed on our current follow-up protocols. 215 patients had surgery during that era, but actually 140 of those were available for follow-up. The Kaplan-Meier survival at 10 years was actually 72%. I think that is reflecting both the higher mortality in patients with chronic pancreatitis and also that these patients, particularly historically, did not get referred for surgery until they were very late in their disease and had a lot of complications. But I do think what was interesting out of this mortality data is that the strongest risk factor for mortality was actually obesity. So patients who had a BMI greater than or equal to 30 had a 9-fold increased risk of mortality. So what about pain improvement, and is that sustained long term? So in that survey that we implemented and before that clinical follow-up data in terms of pain improvement, is pain better than before surgery? Well, we were able to actually get that data for the majority of patients at 10 years. The gray is missing. So this includes missing data in this bar graph for about 15% or so of patients at 10 years. But even accounting for that missing data and assuming maybe they're in the worst category, 80% of these patients at 10 years still identified pain as better than before surgery. And of those we were able to follow up, it was about 10% at that point who said that their pain was the same or rarely worse than before surgery. So the pancreatitis pain in particular is dramatically improved. So you ask patients, do they have the same type of pain they had with pancreatitis? This goes way down to 10 to 20% of the population. What we do see, and I think this is consistent with other groups, is there is some chronic abdominal pain in that population. I think this is a mix of neuropathic type pain, a mix of GI type discomfort. If you underdose on your enzymes or forget a dose of enzyme, you get some cramping discomfort, and other things that we see like chronic constipation. We see some very bad dysmotility issues in this population. But importantly, I'll be talking to patients sometimes and we'll be going through their current abdominal pain history and some of these issues like chronic constipation, cramping pain, all that kind of new type of pain. And then I'll just say, well, do you think it was worth it to have this surgery? And then the vast majority of the time they say, oh yeah, well, this is way better than the pancreatitis I dealt with before surgery. But still, I think opportunities to really improve some of the outcomes. And then the other challenge is if you look at narcotic use, and actually many of these are narcotic users now for musculoskeletal pain or other types of pain. So if you look at all-comer narcotic use, not just for GI abdominal pain, we still struggle with about 40% using some form of opioid at 10 years out. And I think these patients who have been treated for opioids for pain, I see a lot of going back on opioids if they get arthritis, if they have other types of pain. So I think there's some optimization still for opioid withdrawal after the procedure, but patients really perceive a great benefit in terms of pancreatitis pain. So we're trying to figure out how to do better with this population, and one of the ways that we're doing this is we created a multi-center consortium that we call POST, that is for the Prospective Observational Study of TPIAT, and it's a multi-center research consortium. It has now, we started with 8 sites, and now we're up to 12 actively enrolling sites. And the idea behind this consortium is to try to invite every patient who has TPIAT across multiple centers to participate in a study where we are being very systematic across institutions about collecting the same data, including patient-reported outcomes and coordinator interviews at specific time points for things like medication use. And we're also collecting details about hospitalizations, imaging studies, procedures, to be able to do a cost-effectiveness analysis. So the questions we're really trying to address are when is the right time and who is the right patient to undergo TPIAT when we're looking at pain, quality of life, diabetes. And this is funded by the National Institute of Health. So what about the diabetes outcomes after TPIAT? Well, you have heard a little bit about this from Dr. Robertson just before me. This is looking at the patient population, again, kind of looking at some of the same islet mass measures that Dr. Robertson showed you, but we would consider more than 5,000 islet equivalents per kilogram body weight to be a really good islet mass to transplant from someone who has chronic pancreatitis. And when we can get that, we have about roughly 2/3 of patients at 2 or 3 years after surgery off insulin. So when we can get enough cells, we can do quite well in terms of actual insulin independence. When we have fewer cells, we would consider this kind of a moderate number, around 2,000 to 2,500 to 5,000. Those patients are about 1 out of 4, 1 out of 5 off insulin, and where we once in a while but rarely get patients off insulin is if we have a very low islet mass for transplant. So we do want to get more cells when possible. I'm talking about insulin independence here because I knew you'd have some of the C-peptide information, beta cell function information from Dr. Robertson, but I want to emphasize that being on insulin is not necessarily a failure of this procedure. So most of our patients who are on insulin are actually C-peptide positive. Many of them just take 1 insulin injection a day to control their diabetes, many of them with A1Cs in the 5s. So this form of kind of C-peptide positive partial function is a much more manageable form of diabetes, generally speaking, than just taking out their pancreas and having no islet function. So one of the themes, I think you heard a little bit about this morning, but I just want to reiterate, is that if you have someone who is going to likely be a TPIAT candidate, doing another surgery before you get to TPIAT can be detrimental, particularly to your diabetes outcomes. And so you can see these are patients in our population who did not have any surgical intervention before they went to TPIAT. Patients who had a Whipple actually did okay, but once you start getting down to a Pusteau, Fry, distal pancreatectomy, these patients get about half as many islets, and that has to do with both resection of pancreatic mass in the case of a distal pancreatectomy, but also in the case of a Pusteau or a drainage, it has to do with the ability to perform the islet isolation procedure because of the disruption of that pancreatic duct. And so this is particularly important for children with genetic disease. We see less of this now, but we used to see a lot of teenagers who would come back to us after having had a Pusteau as a child somewhere, and then they have recurrence of their pain or ongoing acute pancreatitis because just draining their duct wasn't enough to change the rest of their pancreas. They come back to us for a TPIAT procedure, and at that point, unfortunately, they've both been exposed to more longer duration of pain and narcotics, but also have been exposed to having that surgery where we can't get as many islets from their pancreas. So we do, I think, tend to go to TPIAT in children in particular for that reason. So just a little bit of interesting other data. We talk about islet equivalence, which is an islet mass measure, quite a bit. We talk much less about islet number, but islets are actually different mass, different size. So within the native pancreas, there are small islets, there are large islets. In theory, the large islets have more beta cells because they're bigger, and small islets have fewer, and so it makes sense to measure this as an islet mass, islet equivalence. But one of the observations we do have in the patients who have kind of that marginal islet mass, that 2,500 to 5,000, where they maybe are insulin independent about 25% of the time, when they get more small islets, so this islet size index is basically kind of a rough measure of how big the islets are. When they, in our population of autografts, when they get bigger islets versus small islets, they are much more likely to be insulin independent with small islets or require less insulin. And our patients who have had very large islets in this marginal mass category tend to need a lot more insulin supplementation, have less function. So this is not something we can manipulate. This is really kind of reflective of the native pancreas. But we think in that marginal islet graft group that we just lose too many islets or too many beta cells to hypoxia with the large islet size, and that there is probably a favorable factor in this group in particular to having small islets. So what about insulin independence if we look again now here at children versus adults? So we do see higher insulin independence rates in children, and so if I draw your attention first to this graph over here for insulin independence by age, and this is again the same color coding for children, we see long-term, not necessarily many differences early on, but I'm a very slow insulin weaner. As a disclosure, I think the beta cells do better if they're allowed to really rest during the period of revascularization, so I wean insulin very slowly. And we see over time that our children have a greater rate of insulin independence than adults. But what's really interesting about this, I think, is that this is driven by the really young kids. So there used to be this real hesitation to proceed with TPIAT in a younger child, right? Because this is a huge surgery, and understandably, you want to be careful about doing this in a young child. But it turns out, actually, that the insulin independence rates tend to be the highest in this prepubertal group, and that may be something about the beta cells themselves, that might be something about the recipient. Young children in this age group are more insulin sensitive, have lower insulin needs, so perhaps they're putting less metabolic stress on the islet graft during that early engraftment period, but that's been a fairly consistent observation of ours. So it's not because those children are inappropriately off insulin. If you actually look at the A1C levels at 1 year in this population, you can see the average A1C is about 6.2, 6.3 for the young kids. So this is all comers. Those are insulin dependent and those who are not. Our teenagers tend to have an A1C around 7% on average, and that reflects some of the same compliance issues that we see in a teenage diabetic in this population as we see with our type 1s. What is striking, I think, about this is if I put this side by side with the type 1 diabetes exchange, these A1Cs, these mean A1Cs are much, much better than the mean A1Cs that you'll see in type 1 diabetes in the population. So we are able to really get better glycemic control in this population. So I want to get back to this issue just momentarily about the impact of disease duration. So we have one model, I think, that is relatively pure for looking at the effect of disease duration on the pancreas, and that is the PRSS1 hereditary pancreatitis model. I think it's probably, of what we have, the most consistent of what we have, and now we have about 80 patients who have PRSS1 who have had surgery at our institution. And so we look just statistically, obviously we can't look very well within a single person at this. We don't have arginine stim tests over a 5 or 10 year duration, unfortunately, before pancreatectomy. But if we look statistically at what happens for duration of pancreatitis compared to function of the islets, you can see that, as you would expect, as the duration of hereditary pancreatitis gets longer, the risk of a failed graft goes up. Insulin independence is particularly rare for adults with PRSS1 and those who have had disease for more than 18 years. And statistically, if we looked at the islet equivalents per kilogram and how this changed with time, it was reduced by about 22% for each 5 years of disease. So I typically will tell patients, if you're going to do this, it's not that you have to get in next week. It's, you can get in 6 months or a year, but if you're going to do this, you probably aren't doing yourself any favors in the diabetes world by waiting 3 years or 5 years, because you are slowly losing islets over that time. So a couple unusual events just to keep on your radar. We have seen patients who have gone on to develop autoimmune diabetes after TPIAT. Not many. This was our first observation of that a few years back. Just a patient who happened to be in one of my clinical trials. This is an adult patient. Came back, was insulin independent with more than 5,000 islet equivalents per kilogram, came back at 1 year, had these weird blips of glucose of like 300. We'd started back on a few units of insulin, not thinking much of it, and then by 18 months out, her A1C was 11%, and she had no C-peptide at all, and we did some retrospective testing and found that she had developed type 1 diabetes, and we've seen a few others of these cases. So my rule of thumb now is if you see a rapid graft failure, think of type 1. Even more concerning, we have had one case of metastatic pancreatic cancer in the liver that happened after TPIAT. And so this was a gentleman who was not genetically tested. He was in his 40s, had chronic pancreatitis, so it's possible he had a hereditary disease we didn't know about. He did great with his TPIAT for about 8 months until he came back with new abdominal pain at 9 months and liver lesions, and died a few months later of metastatic pancreatic adenocarcinoma that we presumably infused with the islets, even though all of his imaging and his pre-op markers were negative. So if I have someone with hereditary pancreatitis who's 40 or 50 and is coming through thinking about this, I'm very careful to mention this, risk that we don't know if we might have some pre-malignant cells in there that we infuse. So very lastly, I just want to talk a few minutes about the challenges we have in diabetes remission, because we do lose, even though we try to get as many cells as we can, we do lose some of those cells along the way because of the isolation in the transplant process. So there is stress in the islet isolation. We have the instant blood-mediated inflammatory response around the islets, metabolic stress and hypoxia, and all these factors are proposed to contribute to beta cell apoptosis and islet loss after transplant. And this is one of my areas of research that we'd like to be able to facilitate greater survival of the cells we're infusing. How do we know this happens in people? Because we thought it happened because of animal studies, and very recently there have been some beta cell biomarkers that were developed for type 1 diabetes research, and now we know it happens in people because we're actually able to take a blood sample right after their TPIAT procedure, their islet infusion, and we can see that these beta cell biomarkers are greatly elevated above baseline in the bloodstream. And basically what these beta cell biomarkers are markers of is beta cell death in particular. So it's a marker of dying islets that we infuse. In fact, this happens even before we infuse the cells. So if we look at these same markers in the media of the bag of islets that's brought back from the OR, and we look at the level of these markers in the lab, and then right as the islets are infusing in the OR, we see that there are already islets dying in the prep at the time that we transplant them. So we are very interested in working with some of the diabetes technology. As an endocrinologist, I'm very interested in closed-loop pumps. What we have on the market now is really just the 670G pump, which has some limitations in what we can do. But what we did a few years ago is we actually worked with one of the companies to develop an investigational closed-loop pump model, very primitive, involved a laptop computer that we could use in the hospital to set an algorithm to our patient population in particular. And so these patients, when they were switched off an insulin drip after their TPIAT, we put 7 of them, randomized 7 of them to get a closed-loop insulin pump delivery in hospital, and 7 of them to actually get what we would standardly do with insulin injections. And one of the things that we were able to see is that this is sequential order of average blood glucose. And blue is the closed-loop pump system, and pink is the MDI system, the insulin pen. So what happened is all 7 of the patients who went on a closed-loop pump had tighter glycemic control with less variability than all 7 patients who went on injections. So our goal is to eventually actually translate this to the outpatient setting with some of the approved therapies when they get tight enough to the point that we can use them. Why is that important? Because it improves or reduces the metabolic stress that's placed on the engrafting islets. What are the other clinical trials that are being looked at to improve islet survival? Well, we looked at incretin class drugs, not GLP-1 agonists, but DPP-4 inhibitors. We completed that trial and unfortunately saw no benefit. There are some trials in process with various anti-inflammatory agents, IL-8 inhibitor, TNF-alpha blockade, alpha-1 antitrypsin, both at our center and other centers. There are several places that are looking at alternate sites for transplant, getting back to some of the issues you heard earlier. There are other sites that are looking at some other supportive therapies, and I didn't want to get into this here for our purposes, but I think it would be remiss not to mention that there are some expanded indications being explored in Europe for pancreatic cancer, but not in the US. But of course, our ultimate goal is what we really want to do is benefit the patient. So these are all patients who had a TPIAT, kind of going back to living life and having families and going on trips, a lot of the things that people really struggle to do when they have chronic pancreatitis, and so that's really our goal. These patients are a big part of helping us achieve that goal because they're very generous about participating in research. It's a very altruistic population. And we have a great team that works with our program, so this is not quite all of us, but everyone who could be gathered in a picture of our surgeons, gastroenterologists, endocrinologists, nurses, and other people that take care of these patients. So thank you.
Thank you very much, Dr. Bellin. It was really a beautiful overview over a field that, I mean, just 10 years ago used to be a new field. And now it's really becoming established with all the plethora of information that we have. It's also, I think, of interest to know for medical students and residents alike that clinical research is important. Probably as important as basic science research. Sometimes it doesn't have the glory of basic science research, but don't forget, 80% of basic science research, unfortunately, does not lead to positive results. So clinical research, I mean, like the one that was presented, is extremely important to our knowledge and to the advancement of the areas that we are working in.